My name is Rabindra Watson. I'm an Associate Clinical Professor of Medicine at the University of California, San Francisco and California Pacific Medical Center. And on behalf of my co-authors, I'd like to thank GIE for the opportunity to briefly present our research entitled Safety and Efficacy of EUS-guided coil and glue injection for the primary prophylaxis of gastric variceal hemorrhage. For some background, we know that gastric variceal hemorrhage is associated with high morbidity and mortality, but in contrast to esophageal varices, there's no clear guidelines in terms of primary prophylaxis, and there's an unmet need for a safe and efficacious treatment. Our center has previously shown that EUS-guided coil and glue injection is effective and safe for the treatment of gastric variceal hemorrhage. In our group study, published in 2016 in this journal, we followed a cohort of 152 patients treated with EUS-guided coil and glue injection. 93 out of 100 patients demonstrated confirmed obliteration by EUS, and only 3 patients in this cohort experienced recurrent bleeding, and only 1 episode of delayed PE, which occurred 1 week after the procedure, did occur. Given these positive results, we sought to evaluate the role of EUS-guided coil and glue injection for primary prophylaxis of gastric variceal hemorrhage. So let's take a look at our patients. In our study, we included a total of 80 patients with a mean age of 60 years and a mean MELD score of 12. In terms of the etiology of cirrhosis, the vast majority were due to cirrhosis secondary to alcohol and hepatitis C infection. About half of our patients were on beta blockers, and about half of our patients also had the presence of esophageal varices noted on endoscopy. When we look at the flow chart here, we can see we included a total of 82 patients. 2 of those patients were lost to follow-up. We then were left with 80 patients in our cohort. We performed endoscopic and clinical follow-up in 62 of these patients over a mean follow-up period of 3.3 years, as well as clinical follow-up only in the remaining 18 patients. In the endoscopic follow-up, we were able to demonstrate complete variceal obliteration in 60 of the 62 patients, with 2 patients awaiting their next EUS, and 2 patients within this cohort did experience a post-obliteration gastric variceal bleed. On the other side, in the clinical follow-up cohort only, no reports of variceal bleeding were found. Looked at another way, the majority of varices in our patient cohort were intragastric varices type 1, with a mean size of 22.5 millimeters. We were able to achieve obliteration using a mean of 1.5 coils and just 2 cc's of glue. We achieved technical success in all of our patients with a very low adverse event rate. A total of 4 events occurred. 2 of those were self-limited post-procedural abdominal pain that were managed with analgesics. We did experience 2 episodes of pulmonary embolism. One, as I'd mentioned previously, was a delayed PE that was detected on CT, performed for hemoptysis about a week later. The second event was actually related to a DVT. However, we included that in our analysis as well. Neither of those patients required any interventions other than anticoagulation for that adverse event. If we look at the number of EUS glue coil encounters required, most of these could be achieved in just a single encounter, and the remainder were typically captured after 2 glue coil encounters. Looking at all post-treatment bleeding events, again, there were 2 related to gastric variceal hemorrhage, and there were 3 additional esophageal variceal hemorrhages, as well as bleeding related to a gastric ulcer. Another interesting finding was that 5 patients were able to undergo liver transplant, and none of our patients required TIPS during the follow-up period. We also performed a cost analysis of EUS-guided coil and glue injection for primary prophylaxis, and we calculated a number needed to treat of 7.3, or a cost of $13,439 to prevent 1 episode of gastric variceal hemorrhage, which may indicate that this is a cost-effective therapy when compared with secondary prophylaxis following a hemorrhagic event. To summarize, EUS-guided coil and glue injection appears highly efficacious for the primary prophylaxis of gastric variceal hemorrhage. Variceal obliteration can be achieved in 1 to 2 treatment sessions, with a number needed to treat of 7 to prevent 1 catastrophic bleeding event. It also appears quite safe, with a very low adverse event rate, though we still need to remain vigilant for the risk of glue embolization and ultimately pulmonary embolism in the post-procedure period. Thanks very much for your time.